welcome everyone here this afternoon. I'm really pleased to welcome Dr. Aji Djamali, who's a professor at Tufts University School of Medicine in Maine and chair of the Department of Medicine at Maine Medical Centre for Maine Health. For those who may not know me, my name is Dr. John Jeans. I am an anaesthetist in London, and when I'm not anaesthetising, I lead the CLEAR programme nationally here in the UK. And the title of today's session is a conversation of healthcare challenges from either side of the pond. And it's been an absolute pleasure to know Aji for the last year or two, and we've had a number of very interesting conversations over the time that we've known each other about the differences between the two healthcare systems, between the US and the UK, but also the similarities in terms of the challenges that we both face, and some of the things that we are doing either side of the relatively small pond that we sit across to try and help patients, help our patients, and help give them good quality and high quality care. So what I would like to do without further ado is to have a conversation, sort of a structured conversation with Aji, where we sort of go through some of the challenges. Firstly, a little bit about the US healthcare system as a whole, because it is quite different from the UK health system, and Aji's in a very good place to describe it. After that, we will discuss some of the challenges that we face on either side of the ocean, specifically focusing on access, health inequalities, COVID-19, and some of the workforce challenges, as well as some of the solutions. If anyone does have questions or comments, please do put them into the chat as we go through the session today. But what we'll have is a dedicated time for questions to be answered at the end. So please excuse if we don't answer any questions during the conversation that are in the chat. So without further ado, what I'd like to do is to hand over to Aji to give us a little bit of overview of the US health system. Aji, thank you very much for your time today. It's really great to see you.
Thank you, John. Really a pleasure and privilege to be with you today. And I have also learned a lot from you and your team over the past couple of years. It's been absolutely mind-boggling, the comparisons and the differences and the similarities that we've had. So it's my pleasure to be here with you, and thank you for your help. I don't know if you are able to advance the slides.
Very happy to do so. Very happy to try.
Wonderful. Thank you. Yeah, over the next 10 minutes or so, I was hoping to briefly review the characteristics of the US healthcare system with you all so that I provide enough context for further discussions. Next slide, please. This is my disclaimer. I have to say I am not a healthcare expert and hardly a healthcare expert. However, I do believe I have some common sense, and I can talk to you about some of these topics that are of importance to us. I am also a consultant for CareDx and CSL Behring for clinical trials and clinical studies, which have nothing to do with this presentation. Next slide, please. In the overview of the health system in the US, I would like to start with the very background slide, which is the next one, showing that the average household in the US contributes to healthcare funds in three ways, primarily through the state and local taxes, next through federal taxes, and finally through our employers. And that's where we have cuts in our paychecks that contribute to private health insurance. The state tax contributes later to Medicaid. The federal tax contributes later to Medicare and Medicaid. And overall, all of these will provide the funds to cover our healthcare costs. Next slide, please. I thought it would be helpful to see just how much money we spend in healthcare. In the US, we are probably the leader in the world in terms of healthcare expenditures. That represents approximately 20% of our GDP, compared to around 10% in other comparable countries in Europe and Asia. So very expensive. Next slide will show you that unfortunately these costs are not translated into better life expectancy. In comparison to other comparable countries, you see that the US life expectancy is around 6 years shorter, and the gap is expanding. The next slide shows you a bit more granular information on this, in that you see the average health care cost or spending per capita at the very top for the US in green bars, around 17,000 a year, compared to a life expectancy that's at 76 years. The UK is right below us in terms of life expectancy, but at a much lower cost. In the blue bar, you see the comparable country average. But most interestingly, at the very bottom of this graph, you see Japan, where they spend the least amount of money per capita, and yet they have the highest life expectancy. This is something we can talk about later. Next slide, please. So the question is, where are we spending all this money? $4 trillion every year. 4 trillion are spent primarily in hospital care. 1.2 trillion is hospital care. The second most important area of expenditures is physician services, and the third one is prescription drugs, along with other personal healthcare costs. So that is where most of the money is being spent. And the next slide is going to show a bit of a bit more detail about hospital charges or facility charges compared to the UK or the rest of Europe, for instance. I think this characterizes us in a way that you see, for instance, a charge for an emergency department visit is primarily around facility fees and much less of professional fees. The next slide or two are going to show you two different things that really characterize the US healthcare system, and that's cost variation. I selected these two for you just to have a look. For instance, on this slide, you see the average cost of an emergency department visit in the US. At the very bottom, you see the cost if you went to an emergency department in the state of Maryland, so around $1,500 to $1,600. But the same visit in San Diego, California, at the very top graph, at the very top of this graph, shows you a cost of around $3,500, so about 3 times higher. The next slide will show you another representation of the same thing. The cost of hip or knee joint replacement in Maryland at the bottom is around $24,000, but the same procedure 141 miles away in New Jersey is close to $60,000. So imagine you buy a Toyota in Manchester at $50,000, and then you come to London and buy the same thing for $150,000. I don't think you would be very happy with that. I don't think we would be very happy with that. But the fact is that this is happening, and this variation in cost is one of the biggest challenges that we have in the US. The next slide, I think, is summarizing I can summarize what happened in the previous slides here. So we just talked about the cost variations and the overall cost in the US healthcare and how we contribute to it and where it is spent on.
I mean, Aji, I've been fortunate enough to see these slides before, and I see them again, and I find it quite incredible, really, if I'm honest. The For context for colleagues on the call, uh, we reimburse in the UK about 180 pounds, maybe 200 quid for an A&E attendance. That's in today's today's exchange rate's about $250. So that's what the national tariff is for reimbursement, and that's the same all over the country. And the cheapest version that you saw there was $1,500 at the bottom end in Maryland. Actually, we could spend the entire session discussing this, but from your perspective, I mean, you've worked in several different parts of the country. Do you think that there's a difference in the quality of care that people get for those prices, going to those different institutions, or are there other reasons as to why there's such high variation?
That's a great question, John. I think that there may be differences in the quality of care, but no difference that justifies such a high difference in cost.
Mhm.
That is the biggest, I would say paradox. I could, go over a simple blood test. A simple blood test is the same thing, right? It can cost $20 in Maryland and about $750 to get a comprehensive metabolic panel in somewhere in California. It has nothing to do with the quality of care, just the pricing, the insurances, and the climate, and so forth.
And I suppose the other thing that sort of struck me from looking at those numbers is that if it's not cost, if it's not quality that's the differentiator, you obviously said sort of insurance fees. One of the things that struck me is the professional fees versus the facility fees. One would expect, and this is just being a very naive anaesthetist, that in a sort of more free market environment, that there would be a drive to reduce the costs of those facility fees, so that therefore hospitals could potentially compete upon cost in a local area. Now, obviously, that doesn't quite work, as everyone will know, because people tend to go to the place that's nearest to them. That's the general default for most people. But do you do do you have any inclination as to why the facilities fees are so high?
Yeah, I I don't have the explanation, but I have a solid explanation for it, that it's not, unfortunately, a simple competitive market. Healthcare industry is not based on that. It's based on what the market can bear. And you could take examples of New York City and go across like one block from one institution to another and get an infusion that costs at one place 20,000, at another place 70,000. So it's the what the market can bear. Both of the institutions are going to charge their insurance company, and the insurance company is just going to cover it. And there's no real pushback, and all related really to the contracts that they sign with the insurance companies, and um, again, what the market can bear. I don't know how far this can go, but this is the current climate.
That's a very interesting point. I think very salient, because when you say what the market can bear, people value their health, and so as a result of that, people will um, pay a lot of money to maintain their health, or do things that maintain their health. So from that moment, that statement alone, it makes sense that these high prices can be tolerated, even if you say the outcomes aren't necessarily there. That's very helpful, Aji. And as I said, we could literally talk about this for the entire rest of the call. So I'll probably move on. But one thing that obviously spikes my interest, and obviously everyone will have seen it, although I clicked through to the slides too quickly with my slightly dodgy slide driving, was that this clearly will have an impact in access and how much people access the healthcare. My mind instantly goes to the diabetic, who, whether or not they can afford their insulin and how that would drive their behavior, health-seeking behavior. But have you got any thoughts about access? I know you do, because I'll pop the slides up,
Yeah.
but it'd be great to hear them.
And I don't know if you want me to go through the slides. That's where we are heading. Perfect.
You
Yes.
can
So
do, yeah. I mean, we can
yeah.
a bit as well.
I
Yeah.
think we can go through the slides and then
Yeah.
have the QA session, just like this
Yeah.
past session. Yeah. So the next slide is going to show you where the US stands compared to, again, other advanced countries in terms of healthcare coverage for our people. Most countries have 100% coverage. In the US, we are now at 90%, and we used to be at 80%. That's before the Obamacare or the Affordable Care Act. So we have made progress, but still we have about 10% of our people, so close to 35 million people who do not have insurance. Next slide will show you the impact of that. In fact, in the green bar, you are seeing that about 10% of our people, 1 in 10, are not seeking care or delaying care because of cost. So that's a simple translation of that. And the next slide will also show you other sort of disparities in terms of the average out-of-pocket cost or spending by race and ethnicity in the country. You see that the average cost, out-of-pocket spending is around $829, with differences whether you are white, Hispanic, Black, or Asian, etc. And of course, this is just an observation, and it doesn't mean that all the blacks are paying less because they are it's cheaper for them. It may also mean that they are just not going to healthcare to seek healthcare. Next slide will further show the impact of the Affordable Care Act. For those of you who are not very informed about it, this is an act that was passed in 2010, that was implemented in 2010, and the idea was to expand Medicaid coverage and force more people to buy insurance. What happened is that it actually had a positive impact. You see this on the right top panel, that the number of uninsured people dropped from close to 50 million to now about 30 million. It also helped healthcare delivery to older adults and to those with low income. These are the two bar graphs that you see on the right side. But at the bottom of the graph, you see that we still have a lot of work to do, in that 25% or so of those who qualify as low income poor still do not have insurance. And in the US map, you see some of the states that are still refusing to expand the Affordable Care Act, despite its benefits that are outlined in the higher panels. The next slide can also, so this, I think this is your piece, and I think that I'm actually interested in hearing your thoughts on this. I think you're on mute, John.
Sorry, I had a cough in the background, so I put myself on mute and then forgot to take myself off. My apologies. What I was saying is that one of the interesting things about this slide is the politicized nature of healthcare in the US. Obviously, politics does impact on healthcare delivery in the UK, but it's actually in quite a different way. And it might be an interesting topic for another conversation to go into that in some more detail. I think to go on to your point about access, it is quite interesting because we do have access challenges in the UK, but as colleagues on the call will be aware, although the NHS is a taxpayer funded service which gives free healthcare at the point of use, access is not equal to every single person across the country. We have, sadly, widening health inequalities among disadvantaged populations, and that sort of you inferred earlier, Aji, with the healthcare spend broken down by demographic, of slightly lower in Black and Hispanic, and higher in white and other ethnic groups. In the UK, we do know that we have poor health outcomes and life expectancy in areas with high levels of deprivation, and that does disproportionately affect people of Black and minority ethnic groups. We also know that there's regional differences in the quality of healthcare and health outcomes in the UK, and that these have been relatively long-standing, and that there are consistently efforts to try and improve them, which is positive. But it is a difficult task to deal with some of these entrenched differences. Unsurprisingly, this gives variable quality and experience of healthcare. I mean, as many people know, or people may know on the call, the reason I got into this work with Clear is because of experience with my dad, where if he'd got an operation where he lived in North London, his 5-year survival from gastric cancer would have been 15% if he'd gone to his local hospital. But because he went to a hospital with a different surgeon 10 miles down the road, his 5-year survival instantly increased to 50%, merely because the service was set up differently. The mode of operating and the integration with oncology services was more effective. And that variable quality and experience of care does lead to differences in terms of access to the right healthcare, and that's across acute community and primary care. I think it goes without saying that there's increased behavioural risk to health in areas suffering from high levels of deprivation. That's both from a perspective of smoking, obesity, and lack of exercise. And there's a lot of therefore unmet need for people. That it goes really beyond health. It goes to things like housing, education, and other access to jobs, which obviously in this country is fortunate because it doesn't necessarily impact on your ability to access healthcare. But obviously in the US, if you don't have a job, you're far less likely to have good quality health insurance. Is that fair, Aji, about that statement about the access to work and health insurance?
Yes, absolutely. You're absolutely right. Definitely, there are in each state there are areas that disparities are greater because of access to work and such access to insurance, and although they are not absolutely um, absolutely related, but there's a strong correlation. Definitely, yeah. Neighborhoods, from town, within a town, within a state, yeah, definitely.
Yeah, it's interesting. It's just interesting, the similarities, and I suppose this is one of the things we'll come back to, is that although the landscape is different, there are some quite striking similarities in terms of the challenges that we face. I mean, this slide is obviously there's nothing too groundbreaking here for everyone on the call, but we do know that performance and access to primary care and urgent care does vary across the country, and there has been significant changes in the NHS over the last couple of years to move to new ways of enhancing access, but with virtual consultations, teleconsultations, and such other modalities. But even though the access has increased, the demand still outweighs supply across many different parts of the country, and that's both in the ED setting but also in the primary care setting as well. We do know that there are certain groups that benefit from a more proactive approach. And so there are some quite interesting initiatives uh, going on in certain parts or in isolated areas involving proactive reaching out to high intensity users of urgent emergency care, patients that have frailty, patients that suffer from multiple long-term conditions, and are sort of naturally reticent to seek care in a proactive manner. There's a range of different initiatives going on across the country to tackle this, and they do have that does happen to good effect. And I just appreciate, Aji, this is a little bit off topic from what we planned, but one of the things that's interesting about the NHS is that although it is one NHS, it's really the United States of the NHS, and there's lots of different organisations that tackle different parts of the care needs of people. You work in the Maine medical system, which is a sort of an integrated care system. Do you see the system working together across the different clinical areas to try and improve access, or does it suffer from the similar challenges that we face, which is that we are United States, the NHS, and trying to have a joined up easy access for people for their care needs is a challenge?
Yeah, no, that's another very important question. And I would say yes, our goal, our mission is to work together so the people of Maine are the healthiest in America. So that's our mission. Yeah, definitely. We want to get there. I think we are making efforts every day to break the silos. But this is not easy. You know, it's a health system of 22,000 people and expanding, and the growth is quite significant. We are still not meeting the needs of our people, and I hope, we all hope that in the next 2 to 3 years we'll get the ship back in the right direction, because as we'll talk about it a bit later, you know, workforce has been a major issue for us, besides operational issues and efficiencies that, you know, we all have. Workforce is a significant problem. So yes, we need to, and we are hoping to get.
Yeah, and I think everyone on the call would probably echo that from a UK perspective, is that we have significant workforce challenges, and COVID has created some serious challenges as well when it comes to providing care. I mean, one of the silver linings of COVID was I've never seen NHS bureaucracy fall away so quickly when it came to just trying to change and get stuff done. It was really quite invigorating when it happened. But there was a huge shift in the way that we delivered care, and there's been then another sort of transformational shift to go back to the new normal. And the new normal has obviously involved the reinstitution of all of the structures that sort of fell away briefly, and that new normal, well, as you say, we'll go on to talk about it a little bit later. And I suppose we've actually kind of stumbled onto the topic of COVID rather surreptitiously, because everyone in this, everyone here from a UK perspective has sort of seen and felt the impact of it. But it'd be great to hear from your perspective what COVID meant in the US.
Sure. Thank you so much. Absolutely. I think we can start that section with your help and support, John, through the slides. The next slide is going to show you the overall impact on actually seeking care. 1 in 5 U.S. citizen or American didn't actually seek medical care or delayed it because of the pandemic. So that's the bar graph to the right. You see that 21% of people were affected by this. The next slide will show you the chronic pain that we are going through. This line graph is showing hospital discharges across the country. And you see the big blip in around the time of COVID, how hospital discharges were delayed. And as you can see almost 3 years later, we haven't still reached the pre-pandemic levels. That's like unbelievable. We feel that day in, day out. The average length of stay for us here was, a bit under 6 days pre-pandemic. We went to close to 10 days, and now here we are at 6.8 days. We really want to bring that down, but it's, again, it's a big challenge. The next slide is showing things in maybe a bit slightly different way, but delivering the same message. Here you are showing doctor visits. Doctor visits by Americans have slowed down and also not reached the pre-pandemic level of 85% of people having a physician visit within the previous year. So that is also telling you the long-term impact uh, of COVID. And the final slide on COVID that I selected for you is the one that shows that, fortunately or unfortunately, the bar graph to the right is showing you that 85% of hospital admissions for COVID are happening in those that are not fully vaccinated. So again, a challenge. We are hoping to come out of this institution-based long COVID condition, but we are still suffering.
Yeah, and I think, Aji, I think it's really easy to say that in the UK the story isn't that much different. We've had over 160,000 excess deaths since the pandemic began. So on a background of and total deaths, I think, is around 220,000 from COVID. We've got a significant proportion of the population that now has long COVID, and people haven't come forward for healthcare. It was really interesting talking to colleagues who worked in ED. They said for wave one, there was this huge surge of patients just after the lockdown, and then no one turned up for 3 months. No one wanted to come near a hospital, and that was borne out in the data. Sort of staggering drops in demand initially, but that's all built up into now a large demand for acute and urgent emergency services, and we've also got significant workforce pressures as well. We did have a pretty effective vaccination program that was helpful in ameliorating some of the COVID demand, but I think as a country, we're relatively underbedded compared to the UK, the US, and to other European comparators. So although that was incredibly helpful, the increase in demand, even if it's by a couple of percent, has sort of tipped the system over a little bit. And as a result, we've got longer waits and reduced performance. The next slide is, I mean, I'm sure many colleagues have seen similar graphs like this, but you look at the waiting lists for elective care, and it was gradually growing before COVID, but the last 18 months to 2 years has shown a really steep rise, and we're hoping that plateaus over this year and starts to fall next year. However, and there was a lot of effort going into doing that, and there's a reasonable chance that we should be successful. That's definitely the aim, but there's the challenges are stark, and not like anything I've seen in my clinical practice or in my clinical career. I mean, just to echo the points that you made, we have over 10 million patients who maybe should have come forward for treatment, but haven't, or have come forward later than they otherwise would have. And we also know that we've had higher rates, and this has been patients from Black and minority ethnics have had populations have had higher rates of infections, and also suffered from the outcomes disproportionately, suffered worse outcomes disproportionately from wait lists and delayed presentations and delayed operations, etc. And the long COVID challenge, I said it was about 3% earlier, and that's borne out in the data. And that is, I think, is a really salient point, Aji. We have long COVID for the people, and we have long COVID for the organisations. I think it's entirely true. It's a very nice way of summing it up, and it's just interesting how similar they are across the organisations. I just want to come off the slides for a sec, because you mentioned workforce was a major challenge. So COVID's obviously put a shock to the system, which both health systems are struggling to recover from. Workforce has definitely been an issue here, but from a US perspective, and I don't know whether you'd like to talk or have the slides, but what have been the major workforce issues for you?
Yeah, thank you. It's been felt across the country, and not only in the healthcare sector. Everywhere people are looking to hire, and workforce has been really diminished. We were already pre-COVID, as we will later go through the slides, not in the strongest position in terms of workforce, physicians, nursing, etc. But now it's been really terrible, and that's one of the highest costs. For instance, contract laborers for us have been a significant drain to our finances. More, a significant proportion of nurses have joined traveling agencies for pays that are significantly higher than the place they would work otherwise. And they have the opportunity to work at the same place, but as a traveling nurse. And contract labors for an organization like ours on a monthly basis at the peak were in the $30 to $35 million a month we would be spending on this. And we are still paying not to that rate, but not, but yeah, it's still a big challenge.
And just to give context, Aji, when you say $35 million a month, was that just for the hospital, or is that for the whole health system?
That was for the health system.
Health system, okay. Okay, and so for context for colleagues here, it's a 1,200 bedded health system. If you're just looking.
Yes, the health system, entire health system is around 1,200 beds, but the main hospital, the main teaching hospital, is around 750, and most of the cost was for the main hospital.
Okay. Okay. And in terms of just trying to bring these numbers closer to in the UK, we often talk about agency rates, which is what you're describing, in sort of pounds per hour. And sort of the average agency rate to give you for a nurse, well, they vary, but agency rates for nurses can vary between 40 and 60 or 40 and 70 pounds per hour. So it's like sort of 60 to $180, $60 to $90. Is it similar sorts of rates that you end up paying in the US?
Maybe a bit more. I think the average pay for a nurse is about $30 an hour, but through agencies is 300. So it's really 10 times.
Right. Okay. 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 So I'm it's for context for everyone. Yeah, it's significantly higher. I think that sort of says it all, quite frankly. And actually, just from a COVID perspective, and this is more just a question more of curiosity. Did you have to do massive reorganizations and bed shifts when you had surges and waves within? I've seen that comment from Claire. clearly a nurse. When you had COVID, did you have to do significant reorganizations, expansions of ICU and bed shifts and all of that, and redeployment of staff?
Yeah, yeah. I transitioned my job in intra-COVID, and at both institutions, we had to make significant changes in ICU beds expanding, some of the bed units changing towards COVID care. Absolutely. Yeah. Had
And
to.
how did that affect staff morale?
Staffing, yeah, I mean, huge shortage in staffing, exhaustion, burnout, people out of their comfort zone for many reasons.
Hmm.
And yeah, that was one of the reasons that we fell short in staffing, and we are still feeling the effect of that.
I mean, it's really interesting you mentioned burnout there, but I spoke to a colleague. This is about 3 months ago now, and we were just about to start and doing some anesthesia for the morning. And I said to her, I said, "How are you?" She said, "Oh, I'm okay." And I was like, "Oh, that's great." And she said, I said, "What did you do for the weekend?" She said, "Oh, I went to a barbecue." I said, "Anything exciting happened?" She said, "Yes, actually, something did happen that was exciting." I said, "What?" And she said, "I spoke about the surge and my role in the surge for the first time." So bearing in mind, she's talking about an event that happened nearly 3 years ago, and this was conversation was 4 months ago. And she said, "I spoke about redeployment and surge for the first time, and I was able to do it without crying." And I, obviously said, "Wow, I'm so sorry that you've been feeling like that for so long. It's awful." Um, but I think it just goes to illustrate the point that you made, Aji, that the burnout is substantial. There's only so much you can put people through in these waves of redeployment, and it leaves a mark. Again, another version of long COVID, isn't it? So
Yeah,
so
and in my department, and I can talk about my department, and this is about a year and a half after COVID.
mhm.
uh, Burnout rates are around 50% of
Yeah,
physicians. We
yeah.
are trying to deploy things and redeploy things the way we can to address that. But yeah, it's the long COVID that we're talking.
There you go. It is. It is.
I have to say,
Um,
John, I'm sorry. I have a question here from Amanda, and I don't have the answer to that, Amanda, about, the state of healthcare delivery for mental health. I don't have accurate information other than saying probably it follows the rest of the healthcare challenges, and it's full of paradoxes and discrepancies and access issues.
yeah, it's. I don't know. Actually, just Aji, Mandy, did you want to sort of uh, follow up that question with a little bit more? Because you asked it obviously very well, and Naji's just gone. But is there anything else that you want to ask around it while we're here?
Just sort of generally, is there stigma in terms of accessing mental health services?
Mm.
Yeah, I wish I could give you really good answers. As I said, I'm not an expert, and I don't want to misrepresent data. I do
Hmm.
know access is a problem, because when the chair of psychiatry and I and we as groups we discuss, they have similar issues. As of today, at our senior discussion, we she was actually bringing up the specific topic that for behavioral sciences we have access issues.
Thank you.
Yeah, brilliant, brilliant. Well, actually, do you want to? Shall we just? There was a couple of slides that I think are probably worth just going through ever so quickly about workforce, and then we can open up for uh, final sort of discussion. So
So,
yeah.
yeah, so just sharing with you some workforce data pre-COVID. to show you where the US physician workforce stands amongst comparable countries, and you see that we are in the bottom half of the class, with physicians in Austria leading the field. When on the next slide, you can see that from a nursing perspective, we are in the middle of the pack pretty much. And again, this is pre-COVID, but I assume that it's not that different at this stage. The next slide is interesting for comparison purposes. It shows you that in our hospital organizations, we are number one in the number of administrative leaders. You see at 9.5, the light blue bar graph, 9.5 employees per 1,000 people. Exactly, John. That highlights how many of our organizations are led by CEOs, CMOs, and highly administrative people, as opposed to many other places where CEOs and CMOs are either not there or these are physician-led organizations. The next and last slide on this topic shows you where we rank in terms of hospital employed physicians. Again, adjusted per 100 people across the country, that's where we are exactly. Thank you, John. So in summary, when you compare us to the rest of the world in terms of progressive economic countries, we are at the lower bottom in terms of physician workforce, mid-range for nursing, and probably highest range for administrative leaders in hospitals.
Thank you, Aji. We have slightly different challenges, and I mean that's a very interesting point to reflect on and discuss them shortly. I think from a UK perspective, we have significant staffing shortages. We've got increased vacancy rates that are getting higher and higher. So they've gone from 50 to 60,000 up to 130,000 sort of unfilled posts. Challenges with retention, recruitment is a constant challenge, and that is across the board, both medical, nursing, and other allied health professionals. There is consistent efforts across the NHS to do some good work to upskill and create new roles so that the career paths can be available for clinicians to progress and stay in the NHS in the long term. But there is ever a need to these roles are there, but we clearly need to do more, because otherwise we wouldn't be having these significant gaps that we do have within the vacancy figures that I've just shown. I guess there's just another point to mention about some of the other workforce challenges we have is that we have, this is one that is little talked about, but probably should be talked about more, is that we do have a relatively low level of administrators compared to international comparators, but the level of BAME staff in those senior positions is proportionally underrepresented. It is a problem and it is being addressed, but I think there's still a long way to go before we can rectify that. I'll stop there with the slides because we've covered a lot of ground and we only have about 10 minutes left. But just before I go to questions, Aji, we've discussed a lot of challenges and a lot of similarities. What sort of solves have you been putting in place to try and take those things like that length of stay down from 9 or 10 down to 6.8? What sort of things have you been putting in place? Is there anything that you think we may be able to learn from in this in the UK, because the challenges are so similar.
Sure. Yeah, I will start by saying that, about recruitment and retention. We right now, and I checked this yesterday, we have 400 open positions in the health system to recruit. So Claire, please send me your email. I am going to get you myself. Really a big challenge, but it has improved. It has improved. We were at 800. So through recruitment, as well as reorganization and reducing some of the waste in our operations, we have improved our length of stay. But pathologies are much more different now, John. I'm sure it's the same thing for you guys. Patients are more complex. We cannot find nursing homes for them or skilled facilities for them to send them. Or sometimes we have the nursing homes, but they don't have the staffing to receive the patients. And we are even thinking of going ahead and building a new facility, a new nursing home that's really owned by the health system, right? But where are we going to get the staff for it? So these are all the some of the questions. But where we have been efficient, I think, is by daily briefings, trying to reduce those barriers to discharge through some of the processes that we now call escalation rounds, that where senior leaders are involved in rounds on a daily basis, trying to talk to the physicians that are trying to discharge the patient, and the patient can't get discharged. Now why? Well, they are waiting for an endoscopy and the gastroenterologist is not available, or anesthesiologist is not available, so or the room is not, all that kind of stuff. So we try to, on a case-by-case basis, connect to the different levels of leadership in the hospital to address that. But the biggest thing is workflows and additional recruitment.
I mean, it's really interesting that you say that, because one of the things that we see from the transformation work that we do is that there's a lot of work that can be done on processes to streamline things, and that's across acute, community, and primary care, and also from recruitment. There's a bit about trying to create the roles which you can recruit to, and ensure that the people's jobs can then align well. Excuse me, I'm just got a bit of a cough myself. Bear with me one second. And ensuring that people's jobs change, and so that they can work together differently to be able to recruit new staff into the new roles that haven't necessarily existed before. And we've seen that work very well within primary care and secondary care. And the interesting point that you make about streamlining work processes, a lot of the time better coordination, as you alluded to, with bringing different senior decisions making together is critical. And we've seen roles such as elective care coordinators and sort of different type of care coordinator roles be more and more brought into the system to try and mitigate some of those complex workflows, and they do seem to work quite well. They can generate some gains in productivity. I'm very conscious of time, and I've very much enjoyed talking with you, Aji, but I'm also conscious that there's maybe some people on the call in the last 5 minutes who may have some questions. Obviously, you did earlier, Mandy, and I just want to open up to the floor for the last 5 minutes and see, does anyone have any questions they'd like to ask on anything, really. But given that we've got Aji and his time, I'm sure there may be, apart from sending CVs from nursing colleagues over and sharing job boards, has there been any thoughts or comments or questions about the challenges in the US or the challenges in the UK?
I think I was just going to say, I think in some ways it's reassuring that it's not just us over in the UK, because you often think it's us and what are we doing wrong. with retention and recruitment. So it's quite nice that it is a global. It isn't nice, but it is, you know, it's quite reassuring as a senior nurse to know that it's not just us, and it is a global problem. But we do need to make the professions more appealing in all aspects.
Yeah.
Absolutely.
Yeah. And just actually on that, Aji, have you done and have you performed many changes with the roles in the health system to try and make them more appealing to stimulate recruitment?
Well, I don't know if we have enough time for me to go through that, but trying to, you know, it's always trying to maybe change the culture a little bit, and that's always probably the hardest part, right? In post-pandemic, making people feel valued and valuable, and it's not always about money. And that is what really is at the essence of this. And I've been very fortunate to recruit top-notch people to help me with that. And we have new vice chairs in our department to lead our research efforts, to lead our education and professional development efforts. We are trying to create new vice chair positions for well-being uh, and wellness, and things of that sort. Building infrastructures to make sure people are feeling that they are heard and they can do other stuff that are not just clinical patients and all that stuff. I think that will balance them out a little bit, makes their work a bit more integrated and fulfilling. And as such, I hope that in the next couple of years our burnout rates will be lower. But we need to do a deeper need assessment for that.
Thank you. That's very, very helpful. Mark, Mark, I think had your hand up, and then it was Shruti.
It was just following that point, really, which was, what we see and hear in the UK is a kind of change in the generational kind of expectations around work, about flexibility. The notion of a career isn't the same as those of us saddled with a few more years under our belt. Is that something that you are experiencing and addressing? And I'm aware that I've given you 2 minutes to answer that.
Absolutely, Mark. That's such an important question. I think there's a significant disconnect between our generation and the millennials, and then the Gen X, who have a totally different perspective on life. And that different perspective is not better, it's not worse. And I think that we need to understand that, because their expectations are so different. And we have a lot of clashes around that. And the impact has been significant because we hire them and they leave because they don't want to do this, right? They realize, whoa, hold on a second, what is this? I don't want to do that. And they can go anywhere and do it, as we just talked about. Everyone is recruiting. So those that listen better to them and make the environment culturally more flexible and dynamic for them, then they are the ones that are going to be successful.
Thank you.
Shruti.
Hi, Aji. I have a small person with me as well. I was just curious to try and understand the appetite, yes, of the the healthcare system in general, for innovation in medical care, and changes in medical care, and also then sort of like the management structures that surround the medical care. Because I think that's something that we are interacting with a lot, and trying to make people, be excited about innovation in different aspects of healthcare. So just trying to understand what's that like in the US.
That's such a great question and approach. First of all, I would like to recruit that young lady that's next to you as well. Can I sign her up? But having said that, we are trying to be innovative. The biggest challenge, Shruti, for us, and I don't think we are unique, is to provide non-clinical time to people to be innovative, to do research, to do education, to actually make us better. Most of our priorities are so focused on clinical work because we think that is our, true north, which is not wrong, but we don't spend the right amount of time on innovation, as I was mentioning, on research and education, because that will make us actually so much better. So I think, once again, maybe a bit to Mark's earlier point too, if we invested in some of these important things that are not short-term but mid-term and long-term, we would go much farther. That's part of our job, to try to convince our senior leaders that, yeah, let's do it.
And I think that is a perfect way to end the webinar, which is, yeah, let's just do it. Convince our colleagues and just make things happen. Aji, that was wonderful having this conversation with you for the last hour. Thank you so much for your time. I appreciate you're a busy man, and thank you everyone for your time and participation.